Assalamu alaikum. Welcome to this webinar organized by the Sindh Institute of Urology and Transplant, best known to the North American diaspora as SIUT. This particular forum will highlight the ever-going cancer program at SIUT, which is a little known fact about this very esteemed institution. My name is Pervaiz Rahman. I am a Dow graduate of 1985, and I'm a practicing medical oncologist here at the University of Pittsburgh Cancer Centers. I'm deeply honored, at the same time humbled, that I've been asked to moderate this webinar. And alongside me as a moderator would be Dr. Irfan Rizvi, who is a surgical oncologist, a colorectal surgeon, actively practicing in the Washington, D.C. area. Joining us at the webinar is an extremely robust panel. The individual who does not require any introduction is Professor Abul Hassan Rizvi, founder of SIUT. With him would be Professor Altaf Hashmi, who actually steers the medical oncology program at SIUT. So it'll be very important to hear his views as to where the oncology program started, where is it heading, and what can we do from North America to help SIUT. We also have Dr. Rehan Mohsin, who's a surgical oncologist at SIUT. He's a professor of urology and has mastered the art of robotic cancer surgeries at SIUT, and we would be extremely interested to hear from him as to what his views are. From the medical oncology department, we have Dr. Narjis Muzaffar, who heads the breast oncology and GU oncology program at SIUT. We will also have expert opinion from Dr. Karim Bakhsh Bhutto, who heads the radiation oncology department at SIUT. And then last but not least, Dr. Najib Nematullah, my very good friend, who heads the gastroenterology and hematologic malignancy program at this institution. So as you can see, they are really forging forward with regard to providing multidisciplinary cancer care that envelops not only medical oncology, but also other important facets, which includes oncologic surgery as well as radiation oncology, besides other facets of care that I'm not even privy to, that we will find out today from our panelists. I must add that SIUT is a unique story of a collaborative team, which now extends to the cancer program. I've had the pleasure of doing clinics at SIUT with Dr. Narjis Muzaffar and Dr. Najib Nematullah. So I have a first-hand information as to how they practice. And we will find out from them in the forum today the intricate details as to what drugs are used, how they use it. And I have to add in that the practice that they have set up there is at par with what I do as a practicing oncologist here in the United States. I will now end the introduction before we get the panelists on board to stress on the point that one of the unifying point for SIUT is selfless patient care. The patient is the quintessence to what we do and what we are attempting to do today. They are the fulcrum on which balances the care that we provide. So everything that would discuss today is geared towards making cancer patients receive the best care that they can receive at at any international institution, but here at the doorstep in the heart of Karachi, at the Sindh Institute of Urology and Transplant, now expanding excellence to add a comprehensive cancer program, not only well established and the foundations laid, but we are going to forge forward no matter what in terms of providing extended care to our patients in the city of Karachi and beyond who cannot afford the expensive care that cancer requires. At the same time, to be one of the moderators. Uh, However, I have been to SIUT a number of times, and I thought maybe my experience there would be helpful in furthering the cause of oncology program. And I'm so happy that one of the other moderators is going to be my very good friend, Dr. Irfan Rizvi, who is a practicing colorectal surgeon here in United States in the Washington, D.C. area. I would ask Dr. Rizvi to take over the surgical aspects of the various cancer diagnoses that are treated at SIUT and go into the various aspects of surgery in cancer. We have a robust panel today. Leading the panel is Professor Adibul Hassan Rizvi. He is somebody who does not require any introduction. I think he's a living legend in not only Karachi but Pakistan as a foremost transplant surgeon and a leader in cancer care in our country. We also have Professor Altaf Hashmi, who actually leads the oncology program at SIUT. So we will have the pleasure of hearing from him as to what his vision is with regard to the current treatment we are providing, as well as what the future holds. We also have Professor Rehan Mohsin, who is a surgeon at SIUT, and he will highlight the various surgical programs that they have at SIUT. We'll be very happy to hear from Dr. Narjis Muzaffar. I've had the extreme pleasure of working with her at the breast cancer clinic at SIUT, and she is going to handle not only the breast cancer program questions, but I've been informed also the GU question in medical oncology. I'm so happy to welcome Dr. Karim Bakhsh Bhutto. I was so impressed meeting him. He's a man of great humility who spearheads the very important program of radiation oncology at SIUT, which is a very integral part of a multimodality approach towards cancer. The last but not the least is my very good friend, Dr. Najib Nematullah. Dr. Nematullah not only has a beautiful name, but he's also a beautiful person and a very, very good friend of mine. My reason to accept the moderatorship was I have no embarrassment in saying that my only driving force of coming back to Karachi and coming to SIUT was Professor Adibul Hassan Rizvi. He is not only been my teacher at Dow Medical College, he's been a mentor to many of the classes that have gone through Dow Medical College, but he's also a torchbearer. I think he has proven beyond doubt that if you have a resolve and if you have the purest of sincerity in doing something for the people, you can do it. You can achieve the unachievable. That's what Professor Saab told me when I was leaving SIUT last time, he put his hands on my shoulder and he said, Beta, you can do anything in this world. And I think he spoke with conviction because he has proven that you can do the impossible. I think SIUT is an emblem of an impossible task that was made possible by the sheer resolve of Professor Hassan Rizvi Saab. I will give you a small story. When I came back from SIUT, I met my vice chairman, Dr. Peter Ellis, at the University of Pittsburgh Cancer Center. And I said, Peter, you must look at this model. And can you visit the website? Peter called me 2 days later and he said, Pervez, I've visited so many international countries, but I've never seen a model like this. I don't think anything like this exists in any part of the world. And this is Peter Ellis, who was setting up cancer centers all over the world. So this kind of is a salutation to what you have achieved, and today I'm just being a very small part of it. So SIUT is really a unique story of collaboration, and now this has extended to oncology. What I can tell you is that the level of care, and I know that we need to do much more, the level of care, the standard of care that is applied to patient treatment at SIUT is at par with what we do here in USA. I have no doubts about it. I know that we need to talk about immune checkpoint blockade and so on and so forth, but I would meet patients and I would tell them that आपको जो इलाज यहाँ पर आज मिल रहा है वही इलाज मैं पिछले हफ्ते अमेरिका में करके आया. And I will end by stressing that the reason we are gathered here today, the fulcrum, I will use a very heavy word, quintessence of what we are going to do today is for our patients. And I'm going to finish up by just one little story that has left a lasting impression on my mind. It'll never go away. Dr. Najib was at a funeral and somebody said, there's a new patient with rectal cancer. Can you go and see this patient? I walked in. She was a 35-year-old. She was from a Siraiki locality from Upper Sindh. And I'm seeing her, and I had to give her capecitabine with radiation. So I talked to her. And then when I was done, she stood up. और वो मेरे सामने झुक गई. So I had to step back a few steps. And I looked at the house officer and I said, I don't understand, what is this? And she said, वो चाह रही हैं कि आप अपना हाथ उनके सर पे रख दे. So I was a little bit reluctant, but when she said, no, you have to do that, when I put my hand on her head, she stood up और मुझसे कहने लगी मैं ठीक हो जाऊंगी. मैंने कहा अल्लाह ताला से दुआ करें, बेहतरीन इलाज मिल रहा है, इंशाल्लाह आप ठीक हो जाएंगी. I think that जो वो झुकी है वो मेरे लिए नहीं था, वो SIUT के लिए था. That was a salutation to SIUT. People come there, they have nothing. Even cancer care in US is very expensive. We have to help out our patients to get through the treatment, both financially and otherwise. Pakistan में तो इलाज मुमकिन ही नहीं हो सकती उन लोगों के लिए जिनके पास पैसे नहीं है. लिहाजा this is God's work that you're doing, and I'm absolutely honored that you have asked me to moderate this. I'm going to pass on the baton to our beloved and my mentor, and I have no words to describe him, Professor Adibul Hassan Rizvi. We are looking forward to his words of wisdom and a little insight to how this all started. Professor Adibul Hassan Rizvi, sir.
Thank you, Dr. Rahman. Thank you very much. You have attributed so many things to me that I feel embarrassed. I wish I had done half of it, which you are attributed to me. I'm really thankful to you. People think that there is something which we have been planning for a long time. And then we imagined, put it on a paper, and then created this institute. Unfortunately, this was not the case. I had a desire when I was working in England or in your country, our patient should get the same treatment which the people are getting at Christie, for example. But it was already discussed. Chemotherapy, how you can get radiotherapy is not available, combination therapy is not there. Then how on earth you can have a lab test and the backup services? All this was there, but I used to think at the end of the day that my people in Pakistan are so kind, they are so generous, and if they have got money, they are so uh, careful to put their money for the benefit of others. And that what happened when I came here. The how I got involved in uh, cancer and oncology, it was just an incident, a challenge, because we used to, if you remember Karachi, we used to treat the cancer cases. They were not very much looked after because of paucity of the facilities and beds. And these beds are always considered that they are waste and of course is going to die. So we used to be defeated even before we started the fight because that management needed loving tender care, nutrition, pain killing, stopping the infection, and provide them a clean bed of bed sheets, which we are not able to. And nutrition was equally maintained. But when we started in this, we thought that it was very satisfying. And the thing which was not treatable, look, just was looking that even if we don't treat, the life can be improved, advanced, and the sharp corners of the pain can be removed. And they are, uh, whatever life they have got, they are fully satisfied with that. And so uh, we were responding to the need of the patient. We didn't know that we should name it oncology and then cancer and then radiation. Radiotherapy was not available, it was only in Jinnah Hospital. Chemotherapy was conceptual, it was so costly. And not only that, but when you gave the chemotherapy, there were obviously side effects in certain cases, and those side effects were not being looked after. The chemotherapy used to finish at about 3:30 in the day, and the patient used to be left there, used to go there because there were no other facilities available. It was not that you give chemotherapy, you have to admit the patient, you have to look after the complication, what will happen. That concept was not there. So, having seen all those things the way going on, I was very lucky to get a very good team, which helped me and which was with me all day and night. And that's how we moved and crossed this barrier of difficulties, lack of fund, and then paucity of the medicine which was available. And more people started giving their attention to what we today call oncology. It was taken that it is a very hopeless thing if somebody has got a cancer and just give him loving tender care and give him painkillers and let him quietly uh, die away. Before that, I had worked at Christie's, and there the patient who had uh, advanced cancers, especially carcinoma, bladder, rectum, heart, chest, bone disease, they used to be given a famous mixture, and that mixture they were advised to drink as much as they want. And that was simply a collection of morphine and some uh, factor which will bring you sleep, and some painkiller. It was just a mixture. And that used to be given and left with the patient and just tell them to keep on sipping. And that used to be the actually harbinger of death because they used to drink and drink. Then used to go to sleep, and in that sleep, rarely they developed the cup, they regurgitated, and they used to die. So our job was A, to cut down the pain as much as possible and show him the path of death which was a little painless. And that was very depressing situation. But of course, I was in Christie, and when Christine and Mil Brastin they came, the trial was started, thing was going on. And then there was great enthusiasm in the people that cancer is not untreatable, it is treatable, it is going to be treatable. And then the other role of Christie's Hospital was radiotherapy, and they had mastered the radiotherapy, and protective radiotherapy used to be given, and especially to seminomas and adenomas, and then all these was applied there, or there used to be good result, a good outcome. And that what gave courage to the researchers, to oncologists, surgeons, that this thing advanced at Christie's. And another third thing was, it was a joint effort. You had the pathologist, oncologist, surgeon, physician, radiotherapy, they all used to sit together to discuss a patient. It was a joint effort to fight the disease. And I remember Ryan Marston, I remember Christine, where I was trained, and there they built a clinic. And that clinic was famous that patients used to come from all over the world. And they were discussed, right, and treated. The best at there because the Christie Hospital itself was a very small one. It was not possible to patient to come there. So every morning there used to be ambulances with doctors, and they used to go in particular area where they used to ring up, and they used to go and do outdoor cleaning and used to come. And that is something we couldn't do because a patient, if in England, patient cannot afford to come, cannot afford to have transport or somebody bring him. In Pakistan or India, in our country, it is next to impossible. So I'm planning on thinking that if I get 6, 7 ambulances to start with, and I will create the team, and these teams will go in various directions, collaborate with the local hospitals, and they will go and treat the cases and come back, as it is still going on at Christie. So just uh, to end up, the treatment of cancer is not the individual job. The time that the surgeon was a rolling uh, uh, lion outside the theater are gone. Today, investigation, diagnosis, and medical regime is more important than incision. So, I will advise that we should join hand as we are doing here at SIUT, and everybody should be more important than the other one, and that importance should be in collaborating, discussing the cases, and putting up the scientific treatment which is available properly. Thank you.
One of my pastimes on Saturdays and Sundays is to go into YouTube and listen to your interviews with regard to SIUT program and expansion. So the next question is to Professor Altaf Hashmi. Uh, Professor Hashmi, you've created an excellent, you have laid the very solid foundation of an oncology program at SIUT that I have personally encountered. I have met your physicians. I just have no words. I would use the word awestruck that they would provide care to the patients with such respect, and patients were so happy to come there. And I met scores of patients who were so satisfied with the care given. You have a PET scan machine now, where you send patients and get them back to SIUT. You have CT scanners, you have radiation, you have an excellent surgical program, and then that's embellished by Najib and Nargis and Afsha, if she's still there. I met her too. I have to ask you. I know what you have now. I really want to know, what do you want to do going forward, because we're talking about an expansion of excellence. So we're moving towards excellence, but we also have to expand. And I think over the years, the numbers are going to increase. So what do you have in terms of future, and what would you like for the North American diaspora to come forward and do for you? Thank you.
Thank you, Dr. Pervez. This establishment of this oncology service is not the because of the single person, but I think it is the team, and the team which consists of the medical oncologist, radiation oncologist, surgical oncologist, and the support service which include the pharmacist, psychiatrists, psychologists, counselors, and medical social officers. So this is the team we have, and the idea of this team is to work under one roof. Any facility and every facility which is available under one roof. The patient once come to the oncology center and to the SIUT, that patient doesn't have to go to anywhere else for an investigation, for an treatment. So every treatment, all kind of investigation and all treatment we provide at SIUT. This, if you go back to the history of this oncology services, so it started 48 years back, 1972, when there was only 8-bedded urology department, and we were not there. It was only Professor Rizvi there, and at that time, when there was no concept of specialty clinic, that specialty clinic was established, named as Hematuria Clinic, because there were many patients who comes from the province of Balochistan with hematuria, and they were suffering from bladder cancer. So that clinic was established in 1948 years back in 1972, and then with the passage of time, the progress was there, and then in around 1980, we converted this clinic into an oncology clinic where we used to do all malignancy related to the urology. As time passes, we started doing transplant. Then we come across with the post-transplant malignancy. So that chapter was also added into the armamentarium of our team. And then with the establishment of the liver transplant, the hepatobiliary cancers, the colorectal, all these things we add into our armamentarium. And recently, we started the breast unit also. So this is the workload we have. And we have a building with 100-bedded inpatient and an outpatient, where we have a daycare unit of 12 bed for chemotherapy. And then on the ground floor, we have a radiation unit where we have 2 machines for external beam radiation with high dose brachytherapy incorporated. And out of these 2 machines, the one machine, external beam machine with brachytherapy, is a donation from the North America. I think the cost is around $2.8 million. So this was recently added to our armamentarium. Then we have a diagnostic facilities where we have an CT scan, MRI, angiography, and the PET CT. And we are and if you go through the workload, so we do 6 clinic in a week, where we have 2 filter clinic, where any patient who comes first time, he comes on Tuesday and Thursday, and then once the diagnosis is established, so we assign them the specialized clinic like the bladder cancer clinic, renal cancer clinic, prostate, uh, colorectal, hepatobiliary, and the breast. So they are on the different days. Sometimes the two clinic on a day. So that's how we run. And one day we have a clinic where we do a palliative work. So the pain management, nutritional consult. So that's how we run this clinic. The idea of making this team and adding time to time the new cancer treatment and the new diseases in our armamentarium. The idea is to convert this uh, cancer center, which started as an hematuria clinic, then mainly uro-oncology, to convert this into a general cancer hospital where not only we provide a curative intent, but we should have some satellite unit where we can provide the palliative care to the patient also. Thank you.
What do you foresee for cancer care? How do you plan to expand? Just some ballpark figure, nothing specific. Where do you see cancer care in 2025 and 2030 at SIUT? And that's where the help from North America can be generated.
Thank you. Actually, expansion is in three, four directions. A, the treatment which we are providing is still limited to a small cohort of the population who are either in the cities or they are in big cities and other centers of central. And uh, this is only, I should say, a drop in the ocean. Our rest of the population who need us, who need treatment, they are not having access to this treatment. Why? A, they are in the far off places. B, the hospitals which are there, these hospitals uh, cannot see all these patients, they don't diagnose, and they are in a position, not in a position to diagnose. And then invariably the females are the worst sufferer because hematuria they will never discuss with their spouses. And then even if they have to diagnose, they haven't got money even to go to the first hospital. These are the conditions, and we have to actually fight with all these conditions. And I'm trying to follow the model of Christie. At Christie in those days, I think before you were born, I was doing my house job, and one of the duty was that every morning, one ambulance with a doctor and a technology a technician used to go to a particular city. For example, from Manchester, they will go to Leeds, they will go to Free, they will go to um, uh, other places, and they will treat the cases, see them, and come back. And now, as the time passed, those patients, they either the facilities were provided in those hospitals because they had a reason to provide the facilities, or if it was not possible, then they used to go out in the ambulances, treated, and sent back. So this gives a sense of belonging that a patient, whether he's sitting in Timbuktu or sitting here, his patient belongs to us. We, the doctors, either we should manage, they should be seen there, or we should make every effort to make myself or yourself accessible with treatment to that patient. And that is our moral duty. Once we know that somebody is drowning, you have to make effort to save him. The same way, if somebody is sinking and dying out of cancer, the effort has to be made because I have got full faith the cancer of today will not be cancer of tomorrow. People will laugh it off, but the treatment will be discovered. It's just because cells have got mad, that's all. And the any madness can be removed, especially the ignorance. The madness of ignorance cannot be removed, but any other madness can be removed. And this doctors will succeed in removing this madness. So we should be prepare ourselves for that time. And for that we should educate our children. The thing is that If you come to the medical school, the oncology is just the last question one will prepare for. Although it can be so interesting, but it's not. So until unless we change our attitude towards the disease, we can turn a blind, it is not there. But unfortunately, it is there. We can turn a blind that it did not come. Unfortunately, it will come because so many factors, our dietary factor, atmospheric pressure, the uh, uh, all these uh, oncogenes which are present in so many places and we don't even know. Then the things which we are eating, so many things which are not good, we should not eat, multiparity, smoking, all these things are still going on. So, unfortunately, the disease is going to continue and we have to fight it out. And to fight this disease out, the only way is to to bring in the middle school curriculum oncology as a main part because it makes about 30% of the diseases in developing countries. And then it should be properly taken seriously by the teachers. Then the medicine should be made available, which are so costly, unfortunately, although 50% or more medicines are produced what is known as developing country. So we should make the investigation easy. B, the access of the patient to the doctor should be made easy. And then treatment should be encouraging. It should not be discussed with a high price which is beyond done. And people to jointly spend money and use the center. If there can be Tata centers in Bombay, if there can be Dalmia, can be other centers available. If a center in Madras was created in 20s, when a lady from Madras, she was a gynecologist, came for training in Lady Mary, and then she purchased a machine, got borrowed a machine, but donated to her, went and opened a hospital in the Thest there in the bush, and she started treating, and today is the best hospital, one of the best hospitals in the world. I'm sorry, ladies can't and breed, but she has left her name. And now, believe you me, that any new radiotherapy machine invented in any other country, invariably one copy of that machine is donated to that hospital in Madras
Wow.
in the name of that lady. So we have got a lot of original workers. People have been working. I think we should collaborate with basic scientists. We should collaborate with medical students and medical colleges. We should collaborate with the doctors, and we should collaborate even with the hakims, all those things. And we should join hand and we should try to create the system which can protect us from the disease. For example, creating what are the problems, what are the eatable, what are the oncologic material which are available. Then we should try to investigate early detection of the cases too. There we should take in confidence the lady doctors, especially for female. We should take the doctor in contact. We should even take the hakims. We are collaborating with hakims here because if the patient with hematuria comes, after some time they will send the patient to us. And we have collaborated with late Hakim Said. In the same way, we should not ignore if somebody says that I gave this medicine a patient has recovered. I think we should try, and that is what will be our indigenous research. So I think we have got a lot of hope. We have got a lot of able hands. We have a lot of element in us to sacrifice to invest. The only thing is that we have to have will, and will come from people like you and those of our brothers and our sisters are sitting there and they are sitting on the top of the research. They could come and contribute. And the same thing is going on in India. We are no way not capable of doing these things. So, uh, even if for 6 months In a year, a team of the doctors working in oncology comes and teaches oncology, bewares them of the complications and the negligence which is taking place. I think the enlightenment that will come will be of no limit. And you can go to medical colleges that teach the people, explain the people, take the classes, and people can keep the patient ready. The most important thing is early diagnosis, which is missed.
Thank you so very much again. I'll ask one question to Dr. Narjis Muzaffar and open the forum. After Dr. Narjis, I will pass on the moderatorship to Irfan to perhaps start with surgery and then go with radiation and then more discussion with Dr. Najib. I was looking at the global cancer report from 2018, which cited breast cancer as being the highest cases in the entire world. And obviously, a large part of the morbidity, mortality in Pakistan. And Professor Saab just alluded to the multifaceted difficulties in our patients getting to the right person for the right care. I have had a very clear glimpse of what you're doing. Such an incredible job. I mean, you have gained a lot of my deepest respect for what you do for the patients in Pakistan. So, how have you, what difficulties have you had in changing from what you're doing now and what's ahead of you? How are you? What are your plans for? Again, I'm sorry, I'm sounding like a broken record. What is your plan for the future, or what is your hope that you would change in the next 5 years for your patients with both early stage and metastatic breast cancer?
So it's true that breast cancer is still the most common cancer in women, even in Pakistan. We don't have a national tumor registry, but individual hospital registries show that breast cancer is the most common cancer in women. What we recently started treating breast cancer formally at SIUT. And somewhere around the end of summer of 2017, we established a combined clinic with the surgeons. It's a one-stop clinic. We have Dr. Bushra Shirazi, who's a breast surgeon with a team. There's us, the medical oncologist, and we also have the radiation oncologist, Dr. Uzma and Dr. Kareem, in the same clinic. There's a radiologist where we can just do ultrasounds and biopsies on the same day. So it works very well, the one-stop clinic. So far, we have been, we have had programs on television, on radio about a clinic because many people still think that all we do is GU malignancies. So the number of breast cancer total patients so far that we have treated is around 600 in the past about 3 years, but the numbers are rising every day. So we can tell because the breast tumor board, which happens Monday mornings, is getting busier. We are discussing more and more patients. We have, as you know, you've worked with us in the breast clinic, the standard anthracyclines, taxanes, targeted therapies like trastuzumab and recently pertuzumab. We also have access to, not in all patients, but to CDK4/6 inhibitors. The hospital provides hormonal therapy, AIs and tamoxifen. But of course, we still need more drugs like immunotherapy. But I understand that these are very expensive, so we have not actually asked for those. But I'm hoping that in the coming months or years, we'll be able to get to those drugs. We'll have access. So this is where we are with breast cancer. We encourage women who come with the patients to get screening mammograms, to get physical exam by a surgeon, by us at least once a year. So, patients who now come to us are generally friends or relatives of people that we have already treated. So it seems that whatever we are doing, it's on a small scale, but it's working. And we have the number of breast cancer patients is increasing. We are getting busier now.
So, an extension to my question is when patients get trastuzumab, pertuzumab, and the CDK4/6 inhibitor, which probably is Ibrance, although it could be
Yes.
a different one, does it incur any costs to the patient? Is any cost passed on, or is it all free of charge?
Um, to be honest, there are some patients who can afford these drugs, and they want to buy these drugs. The reason they come to SIUT, many of them, is because they want to get treated at SIUT. They tell us, we can afford to go to other private institutions like the Khan or wherever, Liaquat Hospital, but they want to be treated at SIUT, and they don't want to take medicines from here. So some of them bring their own medicines, like drugs like Herceptin, pertuzumab, and we also get some drugs. There's a SIN government program for CDK4 inhibitors, and we have access to that as well. So some patients will buy their own drug. Not everyone at SIUT gets targeted therapy in breast cancer just because it's so expensive. We haven't been able to give it to everyone. But patients do get it from other places. Sometimes if they can afford it, they buy their own. And that's how we are doing it.
So that would be one of your aspirations, to have CDK4/6 more easily available. I have a patient going on CDK4/6 palbociclib for 5 years now, with fulvestrant. So it's not a short-term remedy sometimes. And this patient is still 49, so a lot to be done when the patient is very young. So thank you so very much. I'm sure that we'll come back to you with regard to renal cancer. I'm going to pass on the moderatorship to Dr. Irfan Rizvi to go the surgical way with regard to cancer care at SIUT. Thank you.
Thank you, Dr. Rahman. Thank you, everybody else. It's really certainly an honor and a privilege to be part of this AUKUS group. And I was listening intently to what Professor Hashmi and Professor Rizvi said, and then Dr. Muzaffar, and of course you, Dr. Rahman. And what Dr. Hashmi said about the evolution of the cancer program at SIUT reminded me of a parallel example that I can think of in North America, where a single specialty in the heart of Ohio, a single specialty hospital, I think it was a couple of brothers, and Pervez, please correct me if I'm wrong, who started an ENT clinic, the Cryle Clinic, that then went on to become what the world now refers to as the Cleveland Clinic. So things start small, but if there is honesty of purpose and this urge to keep responding to the ever emerging and changing needs, then who knows where the destination, where the path takes you. So I'm going to ask a question I have a question of Dr. Rehan Mohsin. Dr. Rehan Mohsin, when Dr. Rizvi was talking about the role of a surgeon in the bygone eras, and I was kind of hoping that I got a chance to practice in those times where a surgeon could stand outside the operating room and roar like a lion. I'd love to roar, but nobody listens to my roar now because I'm part of a multidisciplinary team. And do you think that with ever expanding treatment avenues, patients living longer on chemotherapy, um, cancer no longer being a death sentence that it was, Do you think the role of surgeon has diminished over the years?
Thank you, Irfan. And I also feel very much honored to be a part of this webinar. Uh, uh, to answer your question is this, that currently, you know that it's cancer treatment is now a multidisciplinary type of treatment. And to be very honest, being a surgeon, that we usually get our patient after the scrutiny of our medical oncologist. So, uh, without medical oncologist and radiation oncologist, we can't do anything. But still, I will be staying on the side of a surgeon that without a surgery, without a surgeon, these two disciplines cannot walk. So we are a team, and we should be doing our work as a team. And when we work like a team, then the result is 100%.
Great. No, thank you so much. It was this question was asked partly in jest, just to kind of lighten the mood. Uh, so, can you give us some idea? And this question is directed to you, Dr. Mohsin, but if any of our oncology friends want to jump in too, uh, for the outsider, SIUT is is known as Gurde Ka Aspatal, right? In Pakistan or in North America or in the UK, it's a kidney hospital. Some people even call it the kidney center. Uh, so, for them to comprehend the enormity of the oncology operation at SIUT, sometimes it's difficult. Plus, if you add this layer that all the treatment and not only expensive chemotherapies, some chemotherapies patients are able to afford and they buy their own, but all the investigations and everything else is for free of charge. So it's difficult for people to comprehend. So give us some idea, anybody, of where do your patients mostly come from? Now, Dr. Hashmi said that this was an organic growth. There were urological cancers that needed treatment. And then, of course, once transplant started, there were post transplant malignancies that needed attention. But now, colorectal surgery or breast cancer uh, are is a good percentage of your patients coming from outside, direct referrals from other hospitals, um, or is it mostly from within SIUT?
Well, I can say this, that SIUT is an organization where which not only feeds Karachi, but uh, the, we see the patient from every part of Pakistan, not only from Pakistan but our neighboring country. Like patient contact us from Afghanistan as well. So, oh, and the second part of your question is this: that what type of people come here? Definitely, it's a public hospital. It's open for all, and majority of our patients are those who cannot afford to go to private hospital. But it doesn't mean that only these patients who cannot afford they come to us, but some of the patients are very well to do, but they contact us because we have experience, we have expertise. So it's a mixed blend. We see all the all the patients from every province, from you can say from every city, and from every different parts of our society. And if anybody else want to add in this, welcome.
Dr. Nematullah, do you want to add anything, or Dr. Karim Baksh?
Yes. Actually, not only from SIUT, we have referrals from outside. We are doing certain surgeries which are not available outside SIUT because of being a high volume center. Means like retroperitoneal lymph node dissection, and not many centers are doing in Pakistan. So we are getting refers for these surgeries after chemotherapy. The second referral is word of mouth. The third thing is sometimes patients spend all their money in the middle of their treatment, and then they were referred to SIUT for further treatment. So these are the few ways we get patients over here at SIUT. And when the patient comes and when we ask, "Bhai, ye to गुर्दे का अस्पताल है, आप क्या कर रहे हैं यहाँ पे?" So they say, "No, this is a oncology hospital. The building name is Hanifa Suleiman Dawood Oncology Center." So there is
Amazing.
some perception that this is an oncology hospital, not only the urological oncology center.
It's amazing. It's so amazing you said that, because there are centers in Pakistan and elsewhere in the world who advertise themselves as oncology centers and oncology institutes. And here is an example of a place that just by sheer hard work has, without any advertising, has changed the perception of people who come seeking care. I have a follow-up question, Dr. Nematullah. So there are cancer facilities in Pakistan, and maybe it's a practice also in other parts of the world, where certain patients, if they are beyond a certain stage, are not entertained. They are sent away for palliative care, or they're told that your disease is not curable, so we'd rather focus our attention on people who can be salvaged. And that creates a binary of people who can get care versus people who cannot. Do you have a similar policy, or does anybody who walks through those doors get the attention that their condition requires?
What we are doing at SIUT is we don't reject any patient. Whatever facility we have available, like for urology cancers, we take all the patients, no matter what their stage is, what their condition is. For other cancers, if we have a facility available, we do serve them. Otherwise, we guide them, we give them good advice what to do next, and sometimes we follow them as an outpatient, so that at least in palliative care, their quality of life should be better.
Thank you. Dr. Mohsin, one last question, and then I'll ask Dr. Rahman to step in. About Dr. Nematullah said that there are certain surgeries that are only done at SIUT, and of course, you're a high volume center, no question about that. Certainly in the area of urology, not just in Pakistan, perhaps in the region, but also maybe in some other really complex malignancies where the care is so costly and resource intensive that no single institution can provide everything under one roof. So, in terms of robotic surgery, I know you're a high volume robotic surgeon, and we've had some conversations, and there's been some issues in terms of getting the right kind of technology accessible and available in Pakistan. But has has having access to the robotic platform enabled you to, in some cases, provide better, more precise surgical care to some of your cancer patients?
Yes, definitely, Irfan. We are doing robotic surgery, and we started our robotic program in 2017. And since then, we have done more than 500 cases. And now we can say that we are able to perform some of the complex surgeries. We are operating on pelvic surgeries, like we are doing radical prostatectomies by robots, and we are also doing radical cystectomy. So these are some surgeries which are only available. I mean to say that the robot is only available at SIUT. And very recently, we have also started doing some of the partial nephrectomies. So our main focus regarding robotic surgery is this, that we should do more and more robotic surgeries, especially for pelvic surgeries.
I would like to ask Dr. Najib a question. I know that his specialty of interest, I think, is gastrointestinal, if I'm not wrong, Najib.
Yes.
So when it comes to gastrointestinal, obviously it starts from esophagus and ends in rectum. So can you give us an insight to what parts of GI are you doing, and does it include pancreas? Does it include hepatocellular carcinoma, which I believe would be a very high prevalence in Pakistan because of hepatitis C, B, and other reasons? So, what is your scope of medical oncology practice in gastroenterology? Thank you.
Thank you, Dr. Rahman. Basically, we are very privileged to have very enthusiastic, very good GI team, a GI surgery team over here, and they are doing amazing surgeries. So we are doing esophagectomies, we are doing gastrectomies, partial and total, Whipples, even liver resections for SCC or metastasis, and colorectal surgeries. So we are covering almost all areas of GI malignancies. Uh, and then with surgery, we can do chemotherapy in adjuvant setting, in neoadjuvant setting. We are doing radiation therapy alone, concurrent chemo radiation. So everything is we are doing under one roof. Even in gastric and esophageal cancers, we are doing pre-op feeding jejunostomies, and we have a very good nutrition team which help us in keeping the patient's weight and BMI in good shape so that the patient can tolerate future treatment. So all these things, and we are doing everything very coordinated. We have combined clinics, and not ever on top of tumor boards. We have weekly tumor boards here for GI tumors, and then we have combined clinics on Thursday, where we work with surgeons and radiation oncologists, and it's very helpful for the patient.
Yes, so I have attended the tumor boards in breast cancer, in GU cancer, and GI cancer, and I have to say that the quality of the tumor board is extremely high. I was uh, uh, without surprise completely impressed at how multidisciplinary approach to all these cancers were being actively pursued. So I asked that question because I kind of knew the answer, but I wanted you to spell out for the people who would be watching this as to you have a very wide scope of treatment that you provide. And so the numbers are going to be ever increasing. So the question that I've asked the other members of the panel, what do you see? Where do you see the progress? Do you see the progress in more medical oncologists? Do you see the progress in more medication? I'm sure it's multifaceted, as Professor Adibul Hassan Rizvi Saab said. There are more factors before they walk in to our clinic. There are other unknown factors that we don't know about, and those factors are prevalent only to Pakistan and not to US. So it's a bit unfair on my part to think that I can compare the two systems. Where do you see the help coming? And you can be all open about it, and we'll give you all our ears to listen to.
Okay, I think regarding gastrointestinal malignancies, uh, in surgical area, they are doing laparoscopic surgeries. Not only we are covering SIUT, we are also dealing with the patients from Civil Hospital Karachi, and they are doing a very good job also in surgical care, but they don't have a dedicated chemotherapy and radiation therapy facility. So they refer the patient to us for medical and radiation part. So we are covering both. The only thing which we are still short is targeted therapy. Now, you know that targeted therapy is used in all treatments, all cancers. Most of the cancers, they are used in a palliative setup. but they are getting more and more efficacy. They are showing more and more efficacy, and because of the uh, availability and the cost, both things are the problem. We don't have all those medications available, and the cost benefit ratio is not that we can use those medications at SIUT because of the financial, I think. So that is the one thing. And I think the future of medical oncology is targeted therapy now. And Dr. Rizvi was asking Dr. Rehan Mohsin about the role of surgeon in the future with more evolving medical oncology and radiation oncology. So I think with more organ preservation techniques, like in rectal cancer, now studies are coming up in which you just give chemotherapy and radiation and just follow these patients with uh, observation. And for if there is any recurrence, you can you can do surgery. So same is the case with esophagus. Without surgery, you can cure the patient. So the medications are getting better and better every day. So there will be less surgical input going to be in the future, I think, in oncology.
Okay, that's an excellent overview. Thank you. My next question is going back to Nargis. Can you all hear me clearly?
Yes.
Yes,
Okay.
we can hear you.
Yes. So the cancer that has evolved the most, in at least in front of my eyes over the last 5 to 8 years, or maybe 10 years, is renal cell carcinoma. In the last 2 years, I mean, the treatment has been overtaken by immune checkpoint inhibitors. Now they're coming in doublets. Ipi-Nivo has now taken over both the standard and poor risk patients. So I want to know from you, where does the treatment stand at SIUT, and how do you foresee the next 5 years? Thank you.
Okay, thank you, Dr. Rahman. Because it's a urology center, we have been treating GU malignancies for a long time. I joined in around 2000. I left for some years in between, but even before I came, there was another couple of medical oncologists who had been treating GU malignancies. Um, be- of the total malignancies, urologic cancers that are registered, around 18,000, the highest number is for renal cell carcinoma, of around 5,000 cases, registered cases, and I'm sure we have missed some, but around 5,000. For us, it's still a surgical disease, and we have wonderful surgeons who can do partial nephrectomies, total radical nephrectomies. Where we come in as medical oncologists is, of course, for metastatic disease, occasionally in the adjuvant setting. We have the tyrosine kinase inhibitors. We have access to pazopanib and sunitinib at SIUT, and we have been doing that for the past 3 years. It's very costly, as you know. We don't have access to immune checkpoint inhibitors, we haven't asked for those just because of the financial burden that would create for the institution. But we have TKIs, and we are freely using pazopanib and sunitinib with actually good responses. I remember you doing clinics with us, the combined urology clinics on Tuesdays and Thursdays, and you saw some of our patients who were getting sunitinib and pazopanib and had been on the drugs for several months to a few years. And so we are quite happy with what we have, but obviously we want the best, and we are hoping that at some point we'll get more drugs like immune checkpoint inhibitors and whatever there is to come in the future.
So you were talking about on care
Renal
of
cell.
renal cell carcinoma, right? So that's not my field, so I'll just ask something totally different. And in terms of, I think Dr. Nematullah was also referring to that there is a deluge of patients suffering from different kind of malignancies at SIUT, and your team works. You guys function, all of you function as a team that includes nutritionists and social workers and of course surgeons and radiation oncologists and medical oncologists. Anytime I've traveled to Pakistan frequently, and anytime you drive to SIUT, say 10, 11, 12 at night, there's almost a city outside SIUT, a city of patients, almost a tent city. And surely a lot of them are probably there for their dialysis, but perhaps a lot of cancer patients who travel from far flung areas and need daily treatments if they're getting radiation or if they are in the process of being worked up and being operated on, them and their families are around. And that seems to be an ever expanding cohort of people. Has there been any, I'm sure there's been a lot of thought given to how to accommodate them and how to provide for them. Is there many cancer centers, as you're aware, try and seek subsidized housing for patients who travel from far off areas and just need a place to stay while their loved ones are being cared for? Has something along these lines been looked at or thought of? Anybody, if anybody wants to jump in.
Dr. Rizvi, not in Karachi that I know of. I know there are a couple of centers in Lahore, but again, if you look at the numbers, number of patients that require accommodation, the number of beds that are available in those places, which are called Musafir Khane, is really small. So it doesn't make much of a dent, when it comes to taking care of these patients. So yes, our beds are limited. Obviously, our numbers are huge. Our beds are limited. We try to admit as many patients as we can, especially for radiation, if they're getting with curative intent or palliative spinal cord compression, bony, painful bony lesions, and of course, neoadjuvant or adjuvant setting for other cancers. But we can't admit everyone. And unfortunately, many people have families in Karachi. Not everyone, but many people. There is, as you know, good family support for many patients. But unfortunately, our patients are still, some of our patients have no place to go to, and they live in these cheap hotels waiting for their time to get a bed.
Right. Okay. Yeah. And similar vein, if you're getting patients, say, from southern parts of Punjab or maybe even northern Punjab or Khyber Pakhtunkhwa, and they cannot come for their scheduled follow-up on a routine basis, is there a possibility of maybe seeing some of them virtually, phone consultations or video visits? That's something that is,
sorry. The population that we have, the poor, the very poor, many of them don't have access. They live in small cities where they don't have access to computers or the internet. A lot of them have phones, so they will contact us, especially in the COVID, in this year. From March till even up till now, many patients were trying to contact us on the phone. So they talk to us on the phone. But unfortunately, because they live in small cities or villages or up in the hills in KP, they're not able to have access to the internet or to computers. So that's a drawback. That's something that we haven't been able to do with. I know transplant is more organized, and the numbers are smaller compared to all the cancers that we have. We have. During the COVID times, they were able to get in touch with their patients. We couldn't do it for many of our patients, unfortunately.
Okay. Is that something that if there was an effort towards providing those patients with simple devices that they could use, if not now, maybe 5 years from now, do you think that may help mitigate some of your workload in terms of follow-up moving forward? Because clearly your numbers are going to increase, your reputation precedes you, and people are coming from all over Pakistan now that they know that SIUT is an oncology facility in its own right and not just an appendage of a renal institution. Is that something that perhaps SIUT North America could help with?
That would be great, actually, if we can provide that to our patients. What also, Dr. Rizvi, we have been doing is some of our people who were trained around us, with us, who have graduated, completed the fellowships, taken the exam, and they have gone back to their own cities. Like an oncologist that we know very well now, who also worked at SIUT with us, was at the Irfan, has gone back to Quetta. So many of our patients who come to us for the drugs, in follow-up, they see him. And that's helping a lot of our patients from the Balochistan area. Not many, because it's a big province. Similarly, we have oncologists that we know who are very well trained, who are good in Hyderabad now, in Peshawar, in Sakhar, in Larkana, in Nawab Shah. And we can actually, these are safe doctors, well-trained oncologists. We can refer our patients to them. So they will come for the drugs, but for follow-ups, they can see those doctors there, the oncologists there, and that has been helping. So that's why we are trying to, we tell trainees who are done with the exams and the training to go back to if possible, to their own cities and start with good medical oncology there. So patients don't have to travel to Karachi all the time.
I think that is wonderful. That is wonderful. That not only are you treating patients, but of course this is true expansion of excellence, because you're training people in your own mold, and then of course they're going back to where they originally came from, and they can perpetuate the good practices and the care in the local community. So I think that's a remarkable effort. I think Dr. Rahman is back with us. I'm going to say, I just wanted to, Dr. Nematullah had said something that I just couldn't let go, because it kind of hits me in the core of my being as a colorectal surgeon. He said that treatment for rectal cancer is, the surgical treatment for rectal cancer is probably just going to fall by the wayside. And, unfortunately, it may come to that, because I'm doing TNT all the time, and sometimes I have a hard time finding the scar. But I can bet that hemorrhoids are not going anywhere, and neither is diverticular disease. So I'll still have a paycheck. Thank you. Over to you, Dr. Rahman.
Thank you so very much. That was a very good point. Either Nargis or Najib can jump in here. While I was doing one of your clinics, there are things that I did there that kind of stayed with me when I came back, and they keep coming back into my memory lane over and over again. And Nargis would remember this, that I saw a 17-year-old boy with abdominal carcinomatosis from colorectal cancer, and he was receiving irinotecan, and it kind of hits me that one of the things that I would do when I would see a patient in Karachi would be to start from his social history, to say, "Acha bhai, kahan se aaye ho? Kya karte ho?" This boy told me, मैंने उससे पूछा, मैंने कहा, बेटा कैसी तबीयत है, इलाज कैसा जा रहा है? मुझसे कहने लगा, बहुत अच्छा जा रहा है डॉक्टर साहब, मैं बहुत ठीक हो गया हूँ, मेरे पेट का दर्द खत्म हो गया। तो मैंने कहा कि मतली या उल्टियाँ होती हैं? तो कहने लगा, हाँ पहले 2 दिन होती हैं। मैंने कहा, अच्छा तो क्या करते हो, घर पे होते हो? कहा, नहीं मैं तो फैक्ट्री पे होता हूँ, मैं पैकिंग करता हूँ अपनी अम्मा के साथ, अम्मा भी वहीं जाती है, हम दोनों साथ जाते। मैंने कहा, अच्छा। तो मैंने कहा, तो जब तय कर लेते हो फिर क्या होता है? कहता, फिर मैं वापस आके फिर काम करना शुरू करते हो, 2 दिन रहता है, फिर मैं ठीक हो जाता हूँ। तो वो हर हफ्ते उसको मिल रहा था। बट the thing that struck me was he had no complaints. He was all positive about his treatment. He was positive about his disease. He was back in the workforce. And similarly, Dr. Nargis was very kind to ask me to accompany her for a round at the floor. और वहां पर मैंने एक बच्चे को देखा, आई थिंक ही वाज प्रॉब्ली इन हिज लेट 20s और अर्ली 30s, एंड ही वाज गेटिंग बीईपी कीमोथेरेपी। तो ब्लियोमाइसिन के लिए ही हैड टू कम बैक नेक्स्ट ट्यूसडे। तो हम लोग राउंड करके आगे चले गए, मैं पीछे गया, बिकॉज द इंक्विजिटिव माइंड। तो मैंने कहा, भाई कहाँ से आओ? तो कहा, मैं लसबेला से आया हूँ। तो मैंने पूछा कि क्या लसबेला वापस जाओगे और फिर आओगे अगले मंगल को? तो कहने लगा नहीं साहब, मैं तो वापस तो नहीं जा सकता क्योंकि मेरे पास अब सिर्फ जाने के ही पैसे, अगर चला जाऊंगा तो वापस नहीं आऊंगा। तो मुझसे कहने लगा मैं यहीं रहूंगा। मैंने कहा कोई रिश्तेदार है? कहा नहीं, रिश्तेदार नहीं है, मैं सड़क पे रहूंगा। तो मैंने कहा खाना कहाँ से मिलेगा? तो कहा कोई, आई डोंट रिमेम्बर द नेम ऑफ द जेंटलमैन, somebody by the name of Sailani or somebody who comes and distributes food. तो साइमा शरीफ जो मेरे साथ आई हुई थी लेक्चर करने के लिए कोलोरेक्टल कैंसर में, तो मैंने उनको बताया तो उन्होंने कहा कि यू नो व्हाट परवेज, व्हाट वी नीड टू डू एट SIUT is create some kind of a musafir khana for patients. So my question, I'm so sorry, I kind of got sidetracked here. So how much do you guys involve yourself in social history? I know that you're so inundated with work, with chemotherapy, or you want to treat the patient and get them better and get them out. So how much do you get yourself involved in the social history? और जब आप सोशल हिस्ट्री पता चल सकती है तो कितना आप उनकी इमदाद कर सकते हैं in terms of remedial measures, transport, या so does SIUT provide any such help?
Yes.
You can jump.
Actually, we have a very strong medical social worker department, and we have a good number of MSOs who are working with the patient, especially the patient with renal failure who are on dialysis and the patient who comes for the treatment of cancer. So they interview the patient and they look after them. Even the people who are living in the tent city outside the SIUT, so they look after them. I mean, they provide their clean bed sheet and their blankets and the ration, so they can prepare their food. Now, the problem with the area is that because it's an old part of the city and we don't have much space for any musafir khana or any hotel, we have small 2-3 places identified where the people voluntarily they have established some places for the people, and they're on a very cheap rent they are providing the space to the patient, but that is not sufficient. And the problem is this: at present we don't have the bed capacity. It's only 100 beds we have, and this facility is slowly going toward a general cancer hospital. So there are all kind of cancer people, they are coming here, and we have a building which is under construction just across the road, which is basically a building for the pediatric and cardiology. But initially it was that, but then we expand that building, and now it's a 16-story building. So once this building will be complete, I think it will take a year. Then we will be able to provide, I think, double the bed which we have here. So we will then able to admit more patient there. But the problem of the patient for their where their attendant live, it's still a problem which we cannot resolve at present, because the area is an old city, there are old buildings, and the people they are living around the hospital. So there is no commercial area around the hospital where we can build Musafir Khana there. So this is the
Right.
problem.
So
But we have a building across the Dewan Farooq. Somebody has donated. The problem is because the occupant are there, so we are trying to vacate them. It's a difficult. You see, the people who are living there for the 20, 25 years or 30 years, it is difficult to ask them to vacate, and where they will go. So once that building will be vacated, so we have a chance to demolish, because an old building, and then make a multi-story building for the attendant and for the patient
I see.
who comes for the daycare treatment outside the city.
तो आपका जो नया अस्पताल बन रहा है 16-storied hospital, where did I hear you right? Were you implying that you're going to add oncology beds to it? That's my
Yeah.
first question. And then the second question is, we talked about it a couple of days ago. Would you be very kind enough to give us your a thought that you have in your mind regarding creating an oncology endowment?
Yeah, and in oncology endowment. You see, actually, the problem of capital investment is not, I mean, there, because the people, they donate a machine, the people, they construct a building, but the problem is to run the services. So, I mean, what we are aiming here, if we make a sizable endowment fund, and then the people keep on giving in that endowment fund, and we can use the proceedings of that endowment fund, so we can run the services. I mean, to run the service is a problem, because if you provide treatment free of cost to everybody, so, I mean, then it's a snowball effect. So every time the patient will come, you cannot say no to anybody. If you are not saying no to anybody, then that snowball is constantly swelling. So you need money to to run the services. So in order to run the services, we need a sizable endowment fund. I don't know, I mean, how much we can, but it's sizable endowment fund, so that we can run the services which we have here.
By the way, this is a cherished desire of my friend Professor Altaf Hashmi, that we will get it somewhere and not, but we are committed to free treatment to all, free with dignity, and for the time being, we are doing this. Everybody, whether he coming for chemotherapy, radiotherapy, or some other medication, something, is provided everything free with dignity. And that is, when we say dignity, he hasn't got to stand before you with folded hand. Please, oh my God, yes. I got to say, he should come as if it is his right. I should take it from you like this, should not beg like this. Right? So that is what we have been practicing. It's our desire, wishful thinking of my friend, that we should have a very big endowment. From there, of course, we love to have endowment. We have put some money, and until unless we get the overall support of the doctors, philanthropists, and people who are doing social work in state and other way, until unless they come forward and they realize the importance of SIUT, it won't be possible. The importance of SIUT is one and only one. That is, before SIUT, you people are just kids. We were posted in Chennai hospital, used to be posted to Oncology Service. And there, our Dr. Professor Zaidi, radiologist, he was very good into all services, but he was very strict in the law. He used to take all the precautions. The problem was that he could do that much, not beyond that. Beyond that, the patient with carcinoma tongue, which is very common because of the beetle leaf and all those things. Carcinoma cheek was very common. And then you to get carcinoma of lips, always cigarette was there, we were there. And then GI was quite high, have in GI in 18 years old boy. So these things were quite common. We didn't know what was the cause. We were to blame for the patient for one thing or the other. We haven't had many departments where the patient could stay after 1 or 130. Unfortunately, the disease doesn't disappear after 2. That rogue of the disease is always there. And fatalities disappear after 2, after 1. So they used to sit in the heat weather in Chennai and Siulat, for any hospital. Now we are trying to make a place where the patient has not been treated, going to be treated, and he can rest. And that is what there should be a rest room, or it should be a patient musafir khana. This thing I have seen in Delhi, not in the government hospital, but a private hospital. My brother was being treated. And I think exactly that is what we need. But we need with very liberal hands so that the number will keep on increasing definitely. They will need water, they will need washroom, they will need shower, and they will need food as well. Provide them. And if you can provide that, that will make not all the difference, but lot of difference to helping the people who are otherwise suffering along with the cancer. And these things will have to come when we make the people to realize that is not the drug which they need. They need full night sleep, they need drug, they need a nice bed, and they need somebody to always chat to him and console him. That is going to be.
Dr.
Ji,
Rahman?
Ji.
Uh, I mean, there's a very important question when we are discussing the endowment fund. Why people support SIUT? I mean, it's a very important question. I think the answer is very simple. It is the only cancer hospital which provide comprehensive treatment to all the cancers under one roof. And I think it is the only cancer hospital in the town. There is no other cancer hospital in the town. There are cancer facilities where the people, they're providing daycare facilities, and somewhere the individuals are there, they're working. But the people, I mean, they're not working as a team, which is at the SIUT. We have comprehensive treatment where the surgeon, oncologist, and the support service, they all work together under one roof, and all the facilities are available under one roof. So, I mean, this is the reason the people should support us, so
Right.
that we can expand this facility as
Right.
desired.
Right. So I have
One thing more, and we are not the legitimate child of oncology department. We are illegitimate. We have pushed ourselves. They are very kind and generous that they have accepted us. They are tolerating us. So please, my sincere thanks to oncology department and chief who is sitting there.
I think it's the other way around.
Okay.
so,
Can you? Oh, sorry.
so I think at least we should have Professor Deep Saab's blessing in terms of the endowment, and then obviously the question will go to the SIUT North America with Miraj Saab, and obviously Irfan Rizvi will get involved as well, and then I'm just a foot soldier who's going to follow. So I think we are ready to launch into that, but we'll obviously need your blessing. So with I'm going to take a little bit of a turn because one of the things that I saw on the Globocan map was a very highest incidence of lip and oral cavity cancer in the Southeast Asia region, especially India and Pakistan. So I wanted to take the discussion to Dr. Karim Bhutto in terms of how many head and neck cancers are you seeing, and are you following a multimodality approach? And so, what is happening at the head and neck cancer side of things in terms of treatment?
Regarding head and neck cancers, they are the most common cancers because of the pan, gutka, betel nut, the habits we have. So it needs a multi-modality approach. That is the medical oncology, but still the surgeons are there. They are actually not out of the management. We need a head and neck surgeons, the medical oncologist, the radiation oncologist. The facilities of our radiation oncology, we have the intensity modulated radiotherapy. We have got volumetric arc radiotherapy. We are treating our patients who are needing the concurrent chemoradiotherapy appropriately according to the guidelines with the joint effort of our medical oncology team. So really, this site is actually needs not only the awareness, the prevention, and also the treatment approach.
So, how many head and neck cancer patients are you seeing in your practice, say, in a week or in a month?
Actually, in our clinics, we are seeing 5 to 6 patients because our facilities are limited to the radiation oncology. Most of these cases are going to actually and other centers that has got the surgical facilities, but actually these numbers are very huge, and gradually we are improving our services. So as we have improved in other sites, so the head and neck cancer is the site that we are going to improve also.
Thank you. Thank you very much. Dr. Irfan, do you have any questions before I ask one other medical oncology question?
Yeah, I have a question, and that can be taken up by anybody, any oncologist, or even radiation oncology. We all know that cancer care is very expensive, not only in Pakistan, but in the West, anywhere in the world. Uh, we know that in terms of uh, chemotherapeutic medications, my understanding is that we are net importers. And of course, the import bill of these medicines is fairly high. Has there been any move in your knowledge? Maybe you could enlighten us. Has there been any move towards uh, encouraging local industry to produce basic chemotherapeutic medicines that could reduce the costs? Perhaps, and is there a role? Do you conceive a role for institutions like SIUT or similar institutions of scale to partner with industry to bring costs down?
Dr. Najib, you want to answer?
Sure. Actually, there are basic oncology medicines which are produced in Pakistan, and some are of very good quality. But most of the chemotherapeutic agents and almost all targeted agents, they are imported. Uh, we have good pharmaceutical companies in Pakistan, means Pakistani companies, not international companies who are making other medications, and I think we can partner with them, or we can push them to make good quality chemotherapy and targeted agents to reduce the costs, certainly.
So Najib, would you like to spell out? You said that there are some chemotherapeutic drugs that are made in Pakistan that are good quality and some are not. Would you be kind enough to just list them, just a few of them, the ones that you think are effective?
Means like adriamycin, cisplatin, carboplatin, means the basic medications. If you go to the WHO site and if you look at the oncology medications which are necessary for cancer treatment, means they don't list trastuzumab, pertuzumab, because these are not the necessary medications. These are, I think, for our country, it's more luxurious. But for basic chemotherapeutic agents, which should be available in a country, I think we are making most of them in Pakistan. But for hi-fi medications, and certainly quality, if quality matters, then we go for a imported product, because the quality control in Pakistan is not that great. But there are a couple of companies in Pakistan who are maintaining good quality control, and they are producing good medications.
So I'll make an important point here that immune checkpoint inhibitors, although they may look very attractive from a distance, if you look at all the clinical trials in non-small cell lung cancer or renal cancer, the response rates are somewhere in the 20% range, single agent. So I think this is a good time to sit back and look as to how this will evolve in the next few years. And then once the drugs have gone generic, or there are more immunotherapy drugs available and the prices come down, then we could look at it. So it's not the magic van that we were looking for. I think there's still the immunotherapy world is still going through that evolutionary phase in terms of where do they really stand. But I think they're going to be an important armamentarium in the treatment of cancers to come. So I got my answer. I'm kind of switching gear towards hematological malignancies that you do. That really attracts me because you've got R-CHOP in diffuse large B-cell non-Hodgkin's lymphoma, which is treatable, and you have ABVD. So what is happening on that front? How much of your practice is lymphoma, and how did you start lymphoma, which kind of stands separate in terms of solid tumors? How did you go into hematological malignancy? Can you give us a little bit of an insight?
Sure. Actually, when the patients come with diffuse large B-cell lymphoma, young patients without any money, they have no other place in Karachi where they can be treated free of charge, and it's a curable malignancy. You treat these patients for 4.5 months and they are cured. We have PET scan available, we have radiation therapy. It means we have other facilities available. So we discuss with the team and the SIUT team, uh, Professor Deep Saab and Professor Altaf Hashmi Saab, both are very generous to give us okay to treat malignancies which are curable. So with that, we started treating lymphomas initially, diffuse large B-cell lymphoma, and we are giving rituximab, R-CHOP or rituximab-based therapy to all patients who are B-cell CD20 positive. And we have a very good success rate. The other thing in hematological malignancies is we have most of the renal failure patients. Sometimes they come up with they are diagnosed with multiple myeloma or amyloidosis. So we are using CyBody based therapy, and with that, it's very astonishing to see patient on dialysis getting this treatment and coming out of dialysis, where their kidneys start working, and it will be a big relief if someone get out of dialysis and started good quality of life. I think that will be a very good sigh of relief.
So I'm going to ask you a little bit of a controversial question. So if you have a young man, multiple myeloma, and you've treated and put them into remission, and their bone marrow plasmacytosis shows a complete response, are you a believer in autologous stem cell transplant, or what do you do with those patients? You send them to Aga Khan, Dr. Salman Adil? What does SIUT do as a next step for myeloma patients who have attained remission?
Again, for hematological malignancies, we you see even in diffuse large B-cell lymphoma, you see recurrences with relapses, and those patients need transplant, autologous transplant, and same is the case with multiple myeloma. So one thing we need at SIUT is a bone marrow transplant unit, which we are lacking. So once we start comprehensive cancer care setup at SIUT, I think that is the one thing which we have to start also in order to, because it's a very costly treatment. For autologous stem cell transplant, the cost in Karachi is around 3 to 4 million rupees, which is very difficult for I think probably 5% or less than 5% patient can afford. 95% patient can't afford this treatment. And again, it's a curable treatment. So I think we need to do something to start bone marrow transplant at SIUT.
Excellent. Thank you very much. I have one question for Dr. Karim Baksh, and then I'm going to pass on the baton to Dr. Irfan Rizvi to give the closing remarks, and perhaps some words of wisdom from Dr. Adib Rizvi Sahab. For Dr. Karim Baksh, I'm not a radiation oncologist, but when I attend breast cancer tumor boards, I hear about partial breast radiation. I hear about accelerated breast radiation, where you can finish up the adjuvant breast radiation in a smaller amount of time rather than the traditional 5 weeks. Has SIUT, has it drawn any of those newer techniques into your radiation oncology treatment in terms of going away from traditional 5 weeks to maybe a shorter course of radiation, where the patients can be finished much earlier, and that would mitigate logistical and transport issues for those patients?
Dr. Pervez, as there was a longer treatment of 5 weeks, so we are shorting this to 15 fractions. The treatment is completed within 3 weeks, as we are doing the volumetric arc radiotherapy. So it is very doable, and we are achieving it now with the collaboration of SIUT North America. All these technologies that we have now, and we have got ABC technique. This is a anti-breathing coordination technique. We are starting these cases for our breast cancers. So the radiation can be appropriately delivered to our target volume and actually taking care of the organ at risk, such as the lung and the heart. So with the shorter course of the treatment, it will be more feasible for the patient to come to the treatment only for 3 weeks instead of 5 weeks.
Excellent. Thank you very much. Thank you. So, Irfan, the reason I asked all these questions was to let the audience know that SIUT does not lag behind in terms of the best standard of care treatment that we follow here. We give neoadjuvant chemotherapy, we do robotic surgeries, we do robotic esophagogastrectomies, we do the rectal cancer protocol where you're giving all FOLFOX or, for that matter, KPOX or ZLOX, and then give combined chemotherapy radiation and maybe save about 20 to 25% from getting an AP resection. So these questions kind of highlighted that SIUT, the cancer care that they provide is at par. It's the same language. I mean, it's the same language that we use here. So we have the best treatment available at SIUT, and I think it's time to move this ship forward. We are on a war footing against the cancer, and the war cry is that we do the best, we do the latest, and we're going to move forward. And with Adibul Hassan Rizvi Sahab as a torchbearer, nobody's going to stop us. So I'm going to pass the baton on to Dr. Rizvi, and then perhaps closing statements from Professor Sahab.
Thank you very much, Dr. Rahman. I don't think I have anything else to add. You've comprehensively summarized everything that was spoken about. So thank you so much to you and all the participants. Again, I will reiterate that it is an honor to be a part of this August group. I know it's getting late in Karachi, so I wish you the best and good night, at least from me.
Any last minute statements from any of the participants? We'd love to hear.
I think I am very lucky to be here, and after working for almost 12 years in private setup, means it's very nice to say that I don't have to ask patient about the money. इस मरीज से ये नहीं कहना पड़ता कि भाई कि पैसे आपके पास कितने हैं. That's a one good relief thing an oncologist can have. It's an ideal situation.
And I have visited SIUT so many times. The COVID-19 has really hampered my traveling plans. I was hoping to come to Pakistan end of 2020. That didn't happen. I'll hopefully, inshallah, come end of 2021. But coming to SIUT has been an honor. I envy all of you. I look up to you. I really mean it from the bottom of my heart. I'm not making it up. And it's an honor to be just associated with you, to know you, to know Professor Sahab. I don't deserve to be in the same platform as Professor Adibul Hassan Rizvi Sahab. He's my mentor. But I'm here and I'm honored. And it is a pleasure knowing you all, including Dr. Irfan Rizvi. It has been a pleasure. And I hope that we can take this forward in a little bit of a comprehensive way in the years to come. While you're converting into a comprehensive cancer care, hopefully us in North America will be able to get involved as well. Thank you so very much. Nice to see you all. It's a pleasure.